Let's go ahead and introduce our first speaker for this morning. So our first speaker will be Dr. Dennis Hsieh. Dr. Hsieh is currently the Chief Medical Officer at Contra Costa Health Plan. He was a former St. Joseph as well. And he previously worked as an assistant professor of emergency medicine and the director of social medicine and community health for Harbor UCLA Medical Center, which is part of the Los Angeles County Department of Health Services. He'll be speaking with us this morning about the structure of the US healthcare system, our physician role in the system, and how its design relates to ED physician compensation, often a key factor in job selection. Now for Dr. Hsieh's presentation. Thanks for joining us this morning.
Thanks for having me, Tiffany. Very excited to be here. Good to see everybody. I'm just going to jump right into it so I can keep us hopefully on schedule or ahead of schedule. So a few disclosures. I'm the chair of the ASAP Social EM section and a former legal services attorney. Mentioned that just because I feel like you should always know when you're talking to an attorney, but no conflicts of interest as far as I'm aware. So I'm going to give everyone a couple seconds. I think you've probably all used a system like this before, but really wanted to make this lecture as interactive as possible over Zoom. So if you could just, on your cell phones, text to the number 22333, the Hsieh 735, you'll be able to join the poll. And once you've joined, if you could just text your name so that we know you're in. So I'm going to give everyone a minute to do that. And so looks like it's working for me, so hopefully it's working for others as well. And the main purpose here is I'm going to ask people to answer and respond to some questions. Nice. I see Gigi is in. Tiffany's in. Awesome. For everyone, another couple seconds. Great. Fantastic. It looks like we're hitting critical mass, so hopefully people are getting in, and we'll go ahead and move forward. Sweet. So I think the first thing I wanted to do is to get a little information. You can still see, you can join the poll, but how much do all of you know about the U.S. healthcare system? I think, text either A, B, C, or D. All right, so it looks like we know some, but there's probably something we can mostly learn. So let's jump right into it. So I guess the first question is there a system? Sort of fundamental question. And I would argue there's healthcare, but it's more of a patchwork. And what do I mean by that? So if you look at overall, how do people get insurance coverage, or how are people insured or paying for their care? Just a tad under half are linked to employment. So from your employer, for all of you, probably through either Dignity Health or through Team Health somehow. Non-group insurance is a small amount, sort of paying out of pocket. And then Medicaid, which is one of our public programs, a good amount, 20%, so about a fifth of the population. Medicare, a tad under 20%. Military, a small percentage, but significant, and then, just a tad under 10% for those who are uninsured. So that gives you an idea of the big sources of coverage, which is related to both how the system works in terms of how hospitals and providers such as ourselves get paid, and also how patients pay for care. And then if you look on the right-hand side, in terms of spending, private spending is lower than you would expect given sort of the percentage of the population it covers. And if you look, government spending generally is a bit higher than one might expect in terms of Medicare and Medicaid, taking on sort of a larger proportion than the population they cover. And if you think about it for a second, right, probably not entirely surprising given Medicare and Medicaid together cover individuals who are either lower income, who are older, and generally a little sicker than your healthy 25-year-old resident or attending. And then you can see out-of-pocket expenses are about 10%, and then there's some other spending in there. So I guess, first of all, just jumping in, I think all of us understand private insurance to a large amount, but really the public programs, which make up a lot of the patients we see in the emergency department, I think there's often some confusion. So I wanted to delve in a little bit to talk about Medicaid versus Medicare and talking about the difference there. So tell me whatever you associate with Medicaid. Feel free to just type in some responses, whatever that means, like who's eligible for Medicaid, what kind of patients have Medicaid. Tell me what you're thinking. Well, low income, great. Crappy. Fair. Potentially true. Uninsured. Okay. Dialysis. Nice. Disabled. Yep. So good. So I think people are reimbursement. Nice. So Medicaid, it was established in 1965 under President Johnson. It's administered by the Center for Medicare and Medicaid Services, not surprising, and this is a partnership program between the feds and the states. And what does that mean? It means the federal government usually puts in some money, but then the states also put in some money, and because the states are putting in some money, different states have different criteria. So I think universally, you have to be low income, and that varies based on the state and depending on what category you fall into. Some people put dialysis or disabled or pregnant on there, and depending on your condition you have or conditions, you might be able to be either higher or lower income and still qualify for Medicaid. And some states limit Medicaid to individuals with certain conditions. So you can't just be lower income. You have to be both low income as well as something else, such as lower income and on dialysis, or lower income and over the age of 65, things along those lines. In California, the state has sort of taken the federal program and supplemented it after the Affordable Care Act. So you just have to be low income. You can be a single adult male who is not blind, disabled, on dialysis, under 18, obviously not pregnant, and not parents of a minor child, and still be eligible for Medicaid. But California is one of the states that has broader coverage. And when we talk low income, as you can see from the slide, I'm saying 85 to 200% of the federal poverty level. So sort of the next question I have for everybody is, what is the federal poverty level as of 2020 for a family of 4? Because I know we all think that we may be able to qualify for Medicaid, but, sort of as residents, I know many people feel like they don't make a ton. So it looks like we're going between B and C mostly. So for a family of 4, it's $26,000 a year. So I think this sort of informs some of the challenges we see in the emergency department. As we know, many of our patients with Medicaid come in to see us. It's good that they have Medicaid because that means there's sort of reimbursement for us. But I think the downside is you can tell you have to be pretty low income to be on Medicaid. And we know insurance is expensive. And so for many people who are uninsured, it's often related, at least in the emergency department, more due to they fall into that income category of making too much for Medicaid, but not making enough where they feel like they can buy private insurance. So, that's Medicaid. How about Medicare? What do you associate with Medicare? What kind of individuals are eligible for Medicare as opposed to Medicaid? So 65, I like it. Elderly. So more votes for elderly. Retired. Good. All right. So yeah, Medicare also happened the same time as Medicaid, also in 1965, also administered by CMS. And in this case, it's a federal program. And remember, Medicaid is a federal and state program. So basically, Medicare is a little more uniform because it's really funded directly by the feds and not really by the states. And generally, most people on Medicare are older, greater or equal to the age of 65. And I think the key here is it's linked to how much you've worked. So generally, you have to have worked at least 40 quarters or 10 years equivalent and paid into the system. And then I think, but there are some exceptions to those who are older. If you're disabled and long-term disabled, meaning over 24 months of being disabled and have an ongoing condition, you can be under the age of 65. So you may see some younger individuals whose parents or spouses have worked the 40 quarters who are on Medicare, even though they're not at the age of 65. And I think the key thing to keep in mind for Medicare is that there's no income limit. So Bill Gates gets Medicare once he turns 65, and so does the Medicaid patient as long as they've worked 40 quarters when they turn 65 that you're seeing in the emergency department. So now let's jump over to, beyond Medicare and Medicaid, which are the two big government programs. How does insurance work? And I think in this sense, there's a lot of different ways that insurance work. I think fee-for-service is something we're all probably somewhat familiar with because that's generally how it works for emergency medicine in the most part, meaning if you provide a service, there's a contracted rate that the provider or the hospital or the healthcare system as a whole gets paid or charges. And depending on the contract with the insurance company, they get a certain amount. Then there's sort of, most of this is more a system of care in which you have to think not just in the emergency department, but outside the emergency department, how does an insurance company generally manage a population? So fee-for-service, as we've talked about, is pretty self-explanatory. There's sort of other things where EPOs and HMOs, relatively similar, meaning you can only generally see someone within a network. Obviously, this doesn't apply to emergency medicine because pretty much every insurance company has an exception because an emergency is, by definition, an emergency, and therefore you can't plan to see a provider in network. So pretty much most places for an emergency, all sorts of insurance will pay. But if you're getting them an individual follow-up, sort of these different types of networks kick in terms of where you can go. With an EPO and an HMO, you generally have to go to someone in network. You can't choose to go, let's say if you have Anthem, HMO, or EPO, you can't choose to go to someone not in network. That's a little different from like a PPO, where, as some of you probably have, if you have Anthem PPO, if you go in network or out of network, you can pay a certain amount. Usually, often in-network providers are a little cheaper, but if you go out of network, you aren't barred or prevented from doing that. You generally can go out of network. Your copay or your whatever amount you're paying may be a little higher, but you do have that choice. And generally what happens is because you have that choice with a PPO insurance is generally more expensive than an EPO or HMO. And then health savings accounts, people have probably heard of and are familiar with in terms of thinking about payments, and those are generally a supplement. Either you have some sort of insurance, or if you don't have insurance, you can put a certain amount of money away into those, and you can use the money in there. The general benefit there is sort of a tax deferral or no taxes at all, and you can use that money either for stuff related to your health care, like your contact lens solution, or when you go see a provider, either under a HMO or a PPO for your deductible or your copay, you can use money from there. And then obviously in terms of charity care or negotiated care, for those without insurance, they're generally paying the full cost of service, but the full cost of service is pretty high. So in terms of charity care or negotiated, often what patients without insurance are doing is they are either looking to the system to cover the cost as part of their charitable donation or their community service obligations, or they can negotiate an individualized payment plan with the organization if they have some income to either pay a certain percentage or sort of a long-term payment plan where they're paying a certain amount a month. So in terms of, how payment happens and how these networks work, that's a very high-level overview of some of the different types or structures of insurance, which obviously affect how we as providers are paid. And I think, when we talk about the uninsured, really we're talking about that last category of charity care or negotiated rates. I think it sort of requires a few thoughts because I think most providers outside of emergency medicine don't necessarily think about people who are uninsured because in the outpatient setting, they don't necessarily have to work with individuals who are uninsured. Those who are hospitalists or those at ED docs, as we all know because of EMTALA, we cannot choose to treat someone or not treat someone because they don't have insurance. So I think it's important for us to get a little more understanding of those who are uninsured because often arranging follow-up is often a challenge for us, for those who are uninsured. So I think, the big thing we can see is over time, the number of individuals who are uninsured have generally gone down. And we can see around 2012 to 2015, 2016, that number really dropped. And most people sort of think of that as a result of the Affordable Care Act or Obamacare because of the expansion of Medicaid programs and eligibility for Medicaid programs, as well as the institution putting exchanges in different states in place so that people were able to buy insurance at a more affordable cost, even if their employer weren't able to provide it. But there is still a large percent, as we saw sort of earlier, reflected again on this slide, about 10% of the population that's uninsured. And I think we as emergency medicine docs are very familiar with these individuals who come to the ED for anything from a med refill to sort of more serious problems. And so I guess the question I have is, who are the majority of the uninsured? What do people think? It looks like we have a vote for working poor is running close to individuals who are undocumented, with a small percentage of the votes for people who choose not to buy insurance. And so if we look at those who are not older, most individuals who are uninsured have at least one or more full-time workers in their family. That's 75%. So I think, we often think of individuals, there's a lot of stereotypes out there of people who are lazy, people who don't want to work, and that's why they don't have insurance. I think the data shows that most people who are uninsured actually have someone in their family that's either working part-time or full-time. And part of the reason they're uninsured really is, if you look at the income range, the large part, over half, is between 200 to above 200% of the federal poverty level. So they're not extremely low income. We do have a number of individuals who are low income, but a lot are sort of making a little bit more, but unfortunately probably don't qualify for Medicaid for one reason or the other. And then I guess in terms of what's the biggest reason why people are uninsured? Employer doesn't offer coverage, they lost or changed their jobs. Looks like we're thinking mostly job-related. About pretty much a neck-to-neck race there. So if we look at it, the majority of the reason is it's too expensive. So they make enough not to be able to be on Medicaid, but it's too expensive for them to afford given everything else, with sort of jobs, changing jobs as a leading second reason. And then, about 10% of individuals who are uninsured, it's due to their employers actually not offering coverage. So I think, once again, thinking about this, I think this hopefully dispels a little bit of the stereotypes about individuals who are uninsured. It's often, I think, they're working jobs where they don't make enough to get coverage, and they're making too much for Medicaid. They're not really people who are trying to take advantage of the system. So hopefully we all keep that in mind as ED docs as we take care of these individuals in the emergency department. So I think sort of shifting gears a little bit, now that we've sort of gotten a description of generally how insurance works, different types of insurance, who are those who are uninsured, how are we doing in terms of how is this patchwork system working? And I think you can tell from my graphic, not well. We're number 26 in terms of life expectancy among developed countries, number 29 in terms of infant mortality. And this is not due to a lack of spending, right? We are number 1 in terms of spending. So we're spending a ton of money in the system. But I think, why is this not working well? I think this speaks to a lot of the work that Tiffany and others at St. Joe's are doing with you all. We're spending a lot on healthcare, but not a ton on social care. So in terms of addressing all those other issues, people falling on and off of insurance, people not having housing, people not having access to healthy foods, all those things. And you can see other countries that spend about, as much, if not more, on their social care as opposed to health care. They actually have much better health outcomes. So in terms of spending on health care in addition to social care, we're about middle of the pack compared to all these other developed countries. So just something to keep in mind as you go through, sort of your practice and thinking about what we address in terms of health care. But, sort of jumping to what we are all interested in is payment for physicians. How do physicians in the system get paid? So primary care doctors, we've talked about fee-for-service. You provide a service, you get paid a certain amount. Some primary care doctors, such as those who work at federally qualified health centers, get paid a salary, and potentially some of those who are employed by a hospital system, such as Dignity, also get a salary. Then there's sort of a capitation model, where this generally also applies more to individuals who are within part of a group or running their own practice, where the practice more so gets paid a certain amount per member per month, regardless of how much or how little they use care. And they basically have to manage that population, and it sort of is a model risk sharing, where individuals potentially, sort of the theoretical goal is to incentivize insurance companies to incentivize doctors to practice good medicine, not just to sort of provide a ton of services, because if they keep members healthy and they don't have to access care more, they can keep the difference, and if the members have to use care more, they have to pay out of that capitation. So different models, generally more for primary care, but sort of as a context setting. Hospitals, once again, similarly fee-for-service, where they get paid for what they provide. Some hospitals, especially inpatient, depending on your contract, get paid on DRGs or diagnosis-related groups. This is a Medicare concept where, for example, Medicare has decided an episode of pneumonia generally requires 5 days, and therefore will pay you for X number of dollars to take care of someone who has pneumonia. If you do a better job than 5 days, you keep the difference. If you have quote-unquote poor quality and there's a bunch of hospital-related infections, you go over 5 days, you eat the cost. And then there's other sort of negotiated rates or payment structures, such as percentage of charges, and this really depends more on, how the hospital is set up with every insurance company. And I think many of you have probably seen or heard about different insurance contracts changing with Dignity or other healthcare systems, and this is why the hospital systems are so keen on this, because it affects on how the hospital systems are paid. How about ED docs ourselves? I think, we fall under a sort of a kind of a unique system, but nothing out of the ordinary. Obviously, there are certain systems in which you work, such as the VA, working for a county, or Kaiser, where you get salary and benefits. There are sort of hourly, such as many individuals have heard of locums companies or working per diem somewhere. And then hourly in terms of a partnership structure, like an hourly plus a bonus based on how you're doing, how long you've been with the group, your status within the group, such as gratuity. And then there's sort of hourly plus RVU based on productivity, such as team health at St. Joe's, and then other variations. So I think in terms of this, just, as you think about going to jobs, this is one question. And I think depending on, how much you want to make, what kind of system you want to be in, this is something to keep in mind related to the different insurance structures. But really, once again, it depends on how the groups are contracting with both insurance companies and also the facilities and with you as a provider. And then obviously in terms of tax structures, there's a couple of different ways one can get paid in terms of a W-2, which is, you basically are generally a salaried employee, such as the VA, county, and Kaiser, where you get taxes taken out every month, you get your benefits, sort of the traditional way of someone working for Ford would get paid. Then there's sort of independent contractors, which is an option in many places, such as for Team Health at Stockton, where you get the full amount and then you sort of buy your own insurance, you figure out your own benefits, and you can sort of be incorporated or not incorporated. There's sort of a partnership track, such as through gratuity, and then sort of other tax formats. So I think all mentioning these things not as sort of a comprehensive overview, but as things to think about as you sort of go out to think about employment. These are sort of things you probably want to get more familiar with and ask your future employers what combination of these will be applicable to you. And so that's pretty much a quick overview, I think, of the U.S. healthcare system, individuals on Medicaid, Medicare, and who are uninsured. A little bit about how docs get paid, especially ED docs. I know I have about time, so I'll turn it back over to Tiffany to see if we have time for questions or if we should move forward.
All right. Thank you so much, Dennis, for your time. Thank you. That was excellent. And especially, priming us for how we get paid via understanding the larger system as a whole. So really appreciate your time this morning.
Thank you for having me. Good luck, everybody. And, I've had my contact up on the screen. I'll put it in the chat, but feel free to reach out if I can be helpful.
Thank you.